think it's time that we start looking at ovarian cancer more as a chronic illness instead of an acute illness. This may sound odd, but somebody who has diabetes, we don't just give them insulin when they go into diabetic ketoacidosis or have a problem, or they start to have, end-stage renal disease or having vascular disease. They're constantly getting their insulin. So, hypertension, somebody who has hypertension, we don't wait for them to have a stroke or just repetitive headaches. You're treating the hypertension. Again, I know cancer is different and chemotherapy is different, but, treating ovarian cancer as a chronic illness when it's low volume, using Avastin therapy, I think is very important. Definitely you saw improvement in response rates. You saw it in a doubling of the response rate in the ARIO trial in platinum-resistant disease. When you look at Avastin in the OCEANS trial, again, this was a platinum-sensitive cohort. 50% of the patients were responsive to gemcitabine carboplatin alone. When you gave Avastin, it improved that response rate up to 75 to 80%. A lot of people believe that some of these clinical trials that have included Avastin in upfront therapy as well as recurrent setting, we're not seeing too much of a difference in the treatment arms because everybody's getting Avastin. So bevacizumab or Avastin has been the great equalizer to help improve our response rates, to help improve our PFSs, and hopefully ultimately to help improve overall survival. So, using it over the last 10 to 12 years, I think it's been a great drug. I was a big proponent of it as soon as I saw 218 come out as being positive. I thought that was really, really important. GOG 252 was a combination of an intraperitoneal chemotherapy versus IV chemotherapy using Avastin. Again, I would treat patients with intraperitoneal chemotherapy, and once they've completed that, then place patients on Avastin. It's a little bit of a modification of GOG 252, and we're waiting for some of the results to get published for that trial. GOG 262 showed that Avastin was a great equalizer, and amongst most of the subgroups, patients who got treated with Avastin did well. So to me, I think that the totality of the data has shown that this drug is very safe, it's very effective. There's no doubt about it that we're going to have other options, and to me, I think that's the key. When we're seeing a patient who has advanced stage disease, who's got a chronic illness, who the cancer may mutate and become resistant, then we want to have options. We're having, like we talked about, SOLO-1, the PARP inhibitors coming on board. There may be combinations of PARP inhibitors with Avastin that may improve response rates and prolong these PFSs and OSs. We have immunotherapy coming on board. So as we have these options for our patients, we're going to be able to do good because now we have more options. Our toolkit has more tools to help kind of fix things as they come along. So it's very exciting right now to see some of these combinations with bevacizumab and bevacizumab alone. I can only imagine what's going to happen later on with some of these other trials. The Imagine 50 trial, which is a combination of Avastin with Atezo. To me, those are going to be very exciting results to see. Because again, we're talking about patients who may have severe hypertension or develop proteinuria. They may not be able to stay on Avastin, so we use a different drug. Or somebody that we say, hey, we want to use a PARP inhibitor, however they have toxicity from the PARP inhibitor. Now we can come back to Avastin to say, okay, this is going to be the best maintenance therapy for you because you had toxicities to the other drugs. So to me, that's where we're at. I think that it's going to show that this is a safe drug, this is an effective drug, and we're going to be using it in many different clinical scenarios. I think how I look at it, the changing for ovarian cancer, the standard of care seems like it's going to be changing very rapidly with the numerous trials that are on the horizon. I mean, there's a trial looking at olaparib with bevacizumab for patients who do not have a germline mutation. And so again, it may be looking at, do you want bevacizumab alone? Do you want a PARP inhibitor alone? Or do you want a PARP inhibitor with bevacizumab? So I think as we get the results of these trials in the next few years, the needle's going to be moving on how we need to treat these patients. And our research meetings are very important. We have really good clinical trial design. I'm very fortunate to be working in ovarian cancer, and some of these thought leaders, some of these clinical trialists are just absolutely outstanding with how they're designing not just upfront treatment, but upfront as well as recurrent settings. And drug development has really taken off. So it's a very exciting time to be taking care of women with ovarian cancer. I really feel like Avastin was the tip of the iceberg and really driving a lot of this change as we were improving care for women. So I think that's exciting.